Then circulation, we could see some parts related to blood and circulation like anterior vena cava, pulmonary artery, capillaries of right lung, pulmonary vein, right atrium, right ventricle, posterior vena cava, capillaries of head and forelimbs, pulmonary artery, aorta, capillaries of left lung, pulmonary vein, left atrium, left ventricle, aorta, capillaries of abdominal organs and hind limbs. So these are some types of blood corpuscles. Blood again divided into plasma and cells. Plasma in the sense organic constituents are there along with inorganic constituents. But when we talk about cells, we could see corpuscles and thrombocytes. Corpuscles are of two types, erythrocytes and leukocytes, which are leukocytes are once again classified into granulocytes and agranulocytes, and just thrombocytes stay there. Okay. So then leukocytes, granulocytes and agranulocytes. Granulocytes, eosinophils, basophils, neutrophils. Agranulocytes, lymphocytes and monocytes. So hematopoiesis and formed elements are there. Lymphocytes, lymphoid progenitor cell, hematopoietic stem cell, myeloid progenitor cell, monocyte, basophil, neutrophil, eosinophil. So production of red blood cells. Areas of the body that produce red blood cells. In the early weeks of embryonic life, primitive nucleated RBCs are produced in the yolk sac. During the middle trimester of gestation, the liver is the main organ for production of RBC, but reasonable numbers are also produced in the spleen and lymph nodes. Then during the last month or so of gestation and after birth, RBCs are produced exclusively in the bone marrow. The marrow of the long bones, except for the proximal portions of the humerus and tibia, become quite fatty and produces no more RBCs after about age 20 years. Beyond this age, most RBCs continue to be produced in the marrow of the membranous bones such as the vertebrae, sternum, ribs and ileum. Even in these bones, the marrow becomes less protective as age increases. And the hematocrit, the percentage of blood that is in cells, normally 40 to 45%, and the quantity of hemoglobin in each respective cell are normal. The whole blood of men contains an average of 15 grams of hemoglobin per 100 millimeters. For women, it contains an average of 14 grams per 100 milliliters. Stages of differentiation of red blood cells. The first cell that can be identified as belonging to the RBC series is the proerythroblast. The first generation cells are called basal erythroblast because they stain with basic dyes. The cell at this time has accumulated very little hemoglobin. At the same time, the endoplasmic reticulum is also reabsorbed. The cell at this stage is called a reticulocyte because it still contains a small amount of basophilic material consisting of remnants of the Golgi apparatus, mitochondria, and a few other cytoplasmic organelles. During this reticulocyte stage, the cell passes from the bone marrow into the blood capillaries by diapedesis, squeezing through the pores of the capillary membrane. So, proerythroblast, basophil erythroblast, polychromatophil erythroblast, orthochromatic erythroblast, reticulocyte, and erythrocyte. Erythropoietin stimulates red blood cell production and its formation increases in response to hypoxia. The principal stimulus for RBC production in low oxygen states is a circulating hormone called erythropoietin, a glycoprotein with a molecular weight of about 35,000. Renal tissue hypoxia leads to increased tissue levels of hypoxia inducible factor 1, HIF1, which serves as a transcription factor for a large number of hypoxia inducible genes, including the erythropoietin gene. HIF1 binds to a hypoxia response element residing in the erythropoietin gene, inducing transcription of messenger RNA and ultimately increased erythropoietin synthesis. Factors that decrease oxygenation, low blood volume, anemia, low hemoglobin, poor blood flow, pulmonary disease. Then mutation of the red blood cells require vitamin B12, maturation, cyanocobalamin, and folic acid B9. Final maturation of the RBCs are two vitamins, vitamin B12 and folic acid. Both of these vitamins are essential for the synthesis of DNA because each in a different way is required for the formation of thymidine triphosphate, one of these essential building blocks of DNA. Therefore, lack of either vitamin B12 or folic acid causes abnormal and diminished DNA and consequently failure of nuclear maturation and cell division. Furthermore, the Blastic cells of the bone marrow, in addition to failing to proliferate rapidly, produce mainly larger than normal RBCs called macrocytes, and the cell itself has a filmy membrane and is often irregular, large, and oval instead of the usual biconcave disc. So, maturation failure caused by the poor absorption of vitamin B12 from the gastrointestinal tract, pernicious anemia. This situation often occurs in the disease pernicious anemia, in which the basic abnormality is an atopic gastric mucosa that fails to produce normal gastric secretions. The parietal cells of the gastric glands secrete a glycoprotein called intrinsic factor, which combine with vitamin B12 in food and makes the B12 available for absorption by the gut. Hemoglobin formation. Synthesis of hemoglobin begins in the proerythroblasts and continues even into the reticulocyte stage of the RBC. Therefore, even when reticulocytes leave the bone marrow and pass into the bloodstream, they continue to form minute quantities of hemoglobin for another day or so until they become mature erythrocytes. And iron metabolism. When iron is absorbed from small intestine, it immediately combines in the blood plasma in the beta globulin apotransferrin to form transferrin, which is then transported in the plasma. In the cell cytoplasm, iron combines mainly with the protein apoferritin to form ferritin. Ferritin may contain only a small amount of iron or a large amount. This iron stored as ferritin is called storage iron. Smaller quantities of the iron in the storage pool are in an extremely insoluble form called hemosiderin. And the quantity of iron in the plasma falls low. Some of the iron in the ferritin storage pool is removed easily and transported in the form of transferrin in the plasma to the areas of the body where it is needed. Any characteristic of the transferrin molecule is that it binds strongly with receptors in the cell membranes of erythroblasts in the bone marrow. Then, along with the bound iron, it is ingested into the erythroblastosis by endocytosis. There is a transferrin delivers the iron directly to the mitochondria where heme is synthesized. When RBCs burst and release their hemoglobin, the hemoglobin is phagocytosed almost immediately by microphage, and macrophage released iron from the hemoglobin and pass it back into the blood to be carried by transferring either to the bone marrow for the production of new RBCs or to the liver and other tissues for storage in the form of ferritin. The porphyrin portion of the hemoglobin molecule is converted by the macrophage through a series of stages into the bile pigment bilirubin, which is released into the blood. Anemias. Anemia means deficiency of hemoglobin in the blood, which can be caused by either too few RBCs or a little hemoglobin in the cells. When chronic blood loss occurs, a person frequently cannot absorb enough iron from the intestine to form hemoglobin as rapidly as it is lost. RBCs that are much smaller than normal and have to be little hemoglobin inside them are then produced, giving rise to microcytic hypochromic anemia. Bone marrow aplasia means lack of functioning bone marrow. For instance, exposure to high dose radiation or chemotherapy for cancer treatment can damage cells of the bone marrow, followed in the few weeks by anemia, which may lead to aplasic anemia. In about half of the aplasic anemia cases, the cause is unknown, a condition called idiopathic aplasic anemia. Vitamin B12, folic acid, and intrinsic factor form the stomach mucosa. One can readily understand that loss of any one of these can lead to slow reproduction of erythroblasts in the bone marrow. As a result, the RBCs grow too large with odd shapes and are called megaloblasts. This atrophy of the stomach mucosa, as occurs in pernicious anemia or loss of the entire stomach after surgical total gastrectomy, can lead to megaloblastic anemia. Hemolytic anemia, different abnormalities in the RBC, many of which are hereditarily acquired, make the cell fragile so that rupture easily and they go through the capillaries, especially through the spleen, even though the number of RBC formed may be normal. The term hemostasis means prevention of blood loss. However, a vessel is severed or ruptured, hemostasis is achieved in several mechanisms: vascular constriction, formation of a platelet plug, formation of a blood clot as a result of blood coagulation, and eventual growth of fibrous tissue into the blood clot to close the hole in the vessel permanently. Then vascular constriction. Immediately after the blood vessel has been cut or ruptured, the trauma to the vessel wall causes smooth muscle in the wall to contract. The smaller vessels, the platelets, are responsible for much of the vasoconstriction by releasing a vasoconstrictor substance thromboxane A2 and formation of the platelet plug. On the platelet cell membrane surface is a coat of glycoproteins that pulses adherence to normal endothelium and yet causes adherence to injured areas of the vessel wall, especially to injured endothelial cells and even more so to any exposed collagen formed deep within the vessel wall. The ADP and the thromboxane in turn act on nearby platelets to activate them as well, and the thickness of these additional platelets cause them to adhere to the original activated platelets. Therefore, at the site of a puncture in the blood vessel wall, the damaged vascular wall activates successive increasing number of platelets that attract more and more additional platelets, thus forming a platelet plug. This plug is loose at first, but it is usually successful in blocking blood loss if the vascular opening is small. Then, during the subsequent process of blood coagulation, fibrin threads form. Blood coagulation and ruptured vessel clotting take place in 3 essential steps. In response to the rupture of the vessel or damage to the blood itself, a complex cascade of chemical reactions occur in the blood involving more than a dozen blood coagulation factors. The net result is formation of a complex of activated substances collectively called a prothrombin activator. The prothrombin activator catalyzes conversion of prothrombin to thrombin. The thrombin acts as an enzyme to convert fibrinogen to fibrin fibers that enmesh platelets, blood cells, and plasma to form the clot. Then initiation of coagulation, formation of prothrombin activator. Prothrombin activator is generally considered to be formed in 2 ways, although in reality the 2 ways interacts constantly with each other by the extrinsic pathway that begins with trauma to the vascular wall and surrounding tissues, and by the intrinsic pathway that begins in the blood. Extrinsic pathway for initiating clotting, release of tissue factor. Traumatized tissue release a complex of several factors called tissue factor or tissue thromboplastin. These factors composed especially of phospholipids from the membranes of the tissue plus a lipoprotein complex that functions mainly as a proteolytic enzyme. An activation of factor X, role of factor 7 and tissue factor. The lipoprotein complex of tissue factor further complexes with blood coagulation factor 7, and the presence of calcium ions acts enzymatically on factor 10 to activate factor 10. XA, effect of XA to form prothrombin activator, role of factor V. The activated factor X combines immediately with the tissue phospholipids that are part of tissue factors or with additional phospholipids released from platelets, as well as with factor V to form the complex called a prothrombin activator. Intrinsic pathway for initiating clotting. Conversion of prothrombin to thrombin. The prothrombin activator in the presence of sufficient amount of ionic calcium Ca++ causes conversion of prothrombin to thrombin. The thrombin causes polymerization of fibrinogen molecules into fibrin fiber. Prothrombin is formed continuously by the liver and it is continuously being used throughout the body for blood clotting. Vitamin K is required by the liver for normal activation of prothrombin as well as a few other clotting factors. Then conversion of fibrinogen to fibrin, formation of the clot. The fibrinogen formed in the liver is essential for clot formation. Blood clot is composed of a meshwork of fibrin fibers running in all directions and entrapping blood vessel platelets and plasma. Clot reaction and expression of serum. Within a few minutes after a clot is formed, it begins to contract and usually expresses most of the fluid from the clot within 20 to 60 minutes. The fluid expressed is called a serum. Platelets entrapped in the clot continue to release procoagulant substance, one of the most important of which is the fibrin stabilizing factor, which causes more and more cross-linking bonds between adjacent fibrin fibers.